Thank you so much, Roxana. I want to thank you thank you and Samin for inviting me here. So let me quickly just go through my talk here. Why properly size? Of course, to prevent paravalvular AI, because it's important, as shown here, in fact, that if you have AI, you've got worse outcomes. And what are the key issues that I actually want to discuss? Should it be 3D versus two-dimensional annulus measurement? What should we use, echo or CT? What are the anatomical considerations besides annulus? And how do we occasionally end up fitting the non-optimal size when no other option is available? Fortunately, that's becoming less and less common now. And dealing with paravalvular leak, which is not the topic here. So I think this picture illustrates to you. So there is interaction between the valve and a number of different anatomical structures. So you not only have to look at the annulus, but the sinus of Valsalva, the ascending aorta, the coronary ostia, and the LVOT. All of these things interact with the valve. And I think this anatomical picture basically highlights that, depending upon where the valve would actually sit, the interaction with a number of different anatomical structures. So I think it's important to understand that the annulus is not circular. It's actually not even oval all the time. So it's just variable in shape. And these are just some of the shapes that are actually shown here. So you have to take that into consideration. And in fact, when we first started doing this is old, and by that I say in 2010, we would measure hinge point to hinge point, and we'd come up with the annulus measurement, and then size the valves accordingly. And if you understand this, what is the hinge point? It's basically, if there are 3 leaflets, it's where it touches the annular plane. All right? So if there are 3 leaflets, their position, these points are at 120 degrees, not 180 degrees. So if you measure hinge point to hinge point, you're going to be always less than the 180 degree or the true annulus measurement. So, this just simple illustration kind of highlights that fact. So this is the way we do it now. And in about the last year and a half or 2 years, we've completely relied on CT. And if you look at this is what you'll not only look at maximum diameter, minimum diameter, you look at circumference or perimeter and cross-sectional areas. And you need to get information at multiple levels. And, the level of SDJ, leaflet trip, sinus of Valsalva, and the annulus, of course. And it's very important. This is all very operator dependent. And in fact, you need to define your annular plane very carefully. I think there's a little bit of a learning curve, but it can be easily mastered, and I think you should tend to have people in your group that tend to specialize in this. So cross-sectional assessment is important rather than two-dimensional assessment. CT is not the only method you can do that. In fact, you can use three-dimensional echo and get most of these measurements using the Philips system. And that is actually quite helpful in the lab. So I just want to show you some cases here. So look at this. We thought the 18.5, 20.7. This is a case done in our earlier experience. And in fact, what we did was we did not use CT at that time. So we used a 23 millimeter valve that is paravalvular AI, and when we went back and looked at the CT, which we had accumulated, so we started looking at these things, we found out that the annulus was actually very much oval. So yes, we sized according to this dimension, but look at the maximum dimension. No wonder there was actually a paravalvular leak. And the same thing here, at times you tend to get different measurements in the same patient. In this particular case, we used a 23 millimeter valve. You could have gone either way. There was no paravalvular leak. And if you look at the CT here, it's clear that the cross-sectional area dictated that the measurement, the mean measurements were about 20.7, so it was reasonable for a 23 millimeter valve. Here is a case that we did in 2008. So when we started looking at the CTs, we went and looked at the CT here. This was grossly undersized. No wonder this patient actually had severe AI and had to undergo aortic valve replacement. And here is actually the picture of this particular patient where you can actually see the valve rock, I guess. Not. So what we did was Dr. Hassan Jalavi, who's one of my associates, he basically looked at this in a very systematic fashion and basically showed us that CT-derived parameters actually had the greatest discriminatory value for preventing paravalvular leak. And the same thing was shown by Vancouver group, and both of these manuscripts were actually published in the same issue of JACC. What we also showed was that if you use CT measurements, you can actually significantly reduce the paravalvular leak compared to when you actually use two-dimensional TE guidance. And this has been replicated since in a number of other studies, including this one. So once again, this is looking at the QLab, looking at different things, and you can get the cross-sectional measurements using the three-dimensional echo. And here is another study from our group, basically, which also showed once again that three-dimensional echo was better than two-dimensional echo in terms of predicting paravalvular aortic regurgitation. So why this difference? All right. So I think when you take, this is a very beautiful study. It's an ex vivo cadaveric phantom imaging model, and what we have here is that the MRI is the closest. When you do 3D, there is some spatial resolution loss, and in fact, what you see here is that the measurements are somewhat smaller. If you do CT, there is some hardening of the beam, so the measurements are somewhat larger. So you should keep these things in your mind when you look at whether it is CT or whether it is MRI. So you can size valves properly, and despite that, you might end up with paravalvular AI. And here is one such example. It was sized well, and here it was clear because there was actually a big rod of calcium sticking in the LVOT. So no matter if you size this valve properly, you're going to actually end up with paravalvular AI. Fortunately, that's less of a concern now with some of the technologies that, and I'll show you an example. The SAPIEN 3, for example, this is a lot of calcium in the LVOT, and this is basically the SAPIEN 3 valve, which actually has a cuff at the bottom to prevent paravalvular leak. And what I'm going to show you here is that despite the fact that there is this calcium in the LVOT and the fact that there is a little bit of under expansion of the valve here, there's no paravalvular leak because the cuff, in fact, takes care of the paravalvular leak. So it's not always about undersizing and paravalvular leak. You can go to the other side of the spectrum. Here is a patient, the movie doesn't play, but this particular patient had an aortic root rupture. We did this case in 2009, and in fact, what we found when we went back and looked at the CT was, look at the mitral annular calcium here, okay? So, and this is contiguous with the aortic calcium, and look at the calcium coming into the LVOT. So no wonder, even though we used a 23 millimeter valve in the days when we didn't know better, a few years ago, that this patient actually had aortic root rupture, and this was systematically assessed in multi-center trial here, basically, which suggested that when you do 20% oversizing and balloon dilatation, that's when you end up with the greatest risk of aortic root ruptures, and LVOT and subannular calcification was also an important predictor in this particular study. So here is a case, 90-year-old patient, and the area of the annulus is 449. We do a soft 26 millimeter valve, and you can see there's actually a little hematoma here. This is a contained hematoma. We went back and we looked at the calcium. Once again, look at the LVOT calcium. This patient did just fine, went home in 2 days. And so contained hematomas have a completely different outcome. In fact, none of the patients in the series that I showed you actually had any bad outcomes if it was a contained hematoma, of course, compared to rupture, where the mortality is very, very high. So here is another example of aortic root. This is a case where you would tend to stay away. Look at the calcium in the aortic root. Look at the calcium here in the STJ. Look at the calcium here in the valve. We did this case actually with the protection of the coronaries, and it turned out fine. Lack of calcium at times. So here is a patient, 88-year-old patient. Look at the lack of calcium, not much calcium here. And once again, this patient actually had an embolized valve. It's not very common now, fortunately. I mean, the last 600 cases we've done now, we've had no valve embolizations. But the incidence of this with the older valve was about 1%. So, this valve embolized. It was, parked in the descending thoracic aorta. We went back and did another valve there. And actually got the case done. So there was an example of low calcium. So I'm just going to skip. So there are things that we look at on these volume rendered images that actually help us. So here is a case where we didn't have a 29 millimeter valve. It was borderline large. But what we did here was, because the commissures are fused, we went ahead and did no predilatation and used a 26 valve loaded up with an extra cc and a half, and actually got this case done. The ejection fraction here was actually almost almost 10%, and you can look at the hemodynamics, they're quite satisfactory. And you can also try to understand this when you're dealing with functional bicuspid or bicuspid valves. So in fact, that can end up being somewhat protective against paravalvular AI when you have fused commissures. So here is one example where we actually go ahead and deploy. It's a bicuspid valve, and once again, this is a 26 millimeter sapien valve with no paravalvular aortic regurgitation. So bicuspid valves can be done successfully with balloon expandable and also self-expanding technology. So here is another case of bicuspid valve. Once again, borderline large annulus, and this is a case where we do it a transaortic fashion, and once again done successfully with no AI. So here is another patient where the annulus is very heavily calcified, and in this particular case what you see here is that the first valve moves down because the calcific STJ pushes it down, which we had to extract, but then we go ahead and put another valve in this patient. So I guess let me just quickly go ahead. Here is another case, where the STJ was small. We, protected the left main in that particular case. Here is a porcelain aorta case. So all this information is very, very important. In this particular case, we used a core valve through the carotid approach because that was the only feasible way to sort of get this done, and got the case done. So imaging is absolutely key, not just for sizing, but also for determining a number of other things. So here is the result. Here is a case of low left main coronary artery, which we did with left main protection. So just a couple more minutes here. This is the result. Here is a case with where the valve is actually a valve-in-valve case, but this is a mitral flow. So the leaflets are actually on the outside with a very high chance of coronary occlusion. So we have a stent that is placed in prophylactically. This is a core valve that is being deployed, and we will go ahead and deploy that. So you can see that the left main stent is brought back all the way to the core valve to push the leaflets down. So this is what it looks like, the final result. So let me go ahead and conclude then. Cross-sectional imaging of the annulus is the key to correct sizing during TAVR. 2D measurements are seriously limited due to variations in non-circular anatomy. Valve sizing is most optimally determined by comprehensive assessment of all structures in valve complex rather than isolated annulus measurement. CT provides the best overall assessment because in addition to the cross-sectional measurements of the annulus, it provides the best assessment of the calcification. 3D TE is superior to 2D echo and should be the standard of care during TAVR, and safety and outcomes of TAVR can be incorporated definitely by incorporating these imaging modalities. Thank you.